Well, good evening and welcome everyone. Thank you so much for joining us for another Wellness Webinar Series event with Jefferson Health. My name is Sarah Breckbill and I will be serving as your program facilitator and will present your questions to our panel of experts. This evening, we'll hear from experts in gynecology and primary care to talk about all things menopause, from managing symptoms to treatment options. We've got you covered. Well, thank you so much for submitting your questions in advance, and we'll do our very best to get to as many questions as possible, but may not be able to answer all of them during this virtual event as we received over 300 questions. So thank you. We will certainly have a great discussion. You also have the option to ask questions throughout the webinar. And due to hospital guidelines and privacy, please note that we are unable to comment on specific cases. Well, with that, I want to go ahead and dive in and let's introduce our experts for the evening, starting with Dr. Robin Fay, Dr. Rebecca Jackson, Dr. Sandra Rapp, and finally, Lisa Lent, a certified registered nurse practitioner. Well, thank you all so much for joining us. Before we get into the questions, I'll give each of you a minute or two to just say hello, provide a little background information about yourself, and then we'll dive into our discussion for this evening. So, Dr. Fay, we'll go ahead and start with you. How are you doing this evening? Oh, and I think you might be on mute. Perfect.
Sorry about that.
No worries. All right.
I'm a board certified OBGYN. I've transitioned to a focus of gynecology, menopause, sexual health, pelvic pain, and dermatology. I'm a certified menopause practitioner, and I also chaired the consumer education department at the Menopause Society. I was the second physician in the state of Pennsylvania to become a sex counselor, and I contribute to the evidence-based sexual health guidelines. I love teaching residents, students, at nursing women in all their stages of life, mature, and help patients dealing with menopause, sexual health, and to support cancer survivors to achieve sexual wellness.
All right. Well, thank you so much for joining us. We appreciate it. Let's turn to our next person for this evening, who will we introduce, Dr. Jackson. How are you doing this evening? Great to have you.
I'm great, thanks, Sarah. I am a generalist OBGYN doing full scope OBGYN in Center City. I see patients at 833 Chestnut Street. I've been here since 2013, and I've been a Menopause Society practitioner since 2014. And I like to see people going through perimenopause and menopause and help them through that transition.
All right. Well, thank you. Great to have you here. All right. And next up, Dr. Rapp. How are you?
I'm good. How are you, Sarah?
Doing well.
So I'm Sandy Rapp. I'm practicing at Abington Hospital. I've been there since 2001. I also did combination obstetrics and gynecology and still see OB patients in the office, but have stopped delivering within the past 3 years to focus more on menopause and perimenopause care.
Okay. All right. Thank you. And last but not least, Lisa.
Hi, I'm a board certified women's health nurse practitioner. I've been at Jefferson in Center City for 13 years now. I provide OB and GYN care to a full range of women. Before I became a nurse practitioner, I was a labor and delivery nurse for 12 years. So my whole career has been in women's health.
All right. Well, we certainly have our panel of experts, so thank you. And let's dive into it because, as I said, we received a ton of questions. So we'll have a great discussion tonight. Okay, so our first question. Let's start off with hormone therapy, which is a question that we received a lot of. We received this question a lot. So Dr. Fay, I will start with you. Can you discuss what hormone therapy is?
So when we near menopause, estrogen, progesterone, and testosterone all start to diminish. Hormone therapy refers to the use of these hormones, most commonly estrogen, sometimes combined with progesterone, to treat the symptoms caused by either hormonal imbalance or decline, especially during menopause. So in menopause, hormone therapy is typically used to relieve these symptoms such as hot flashes, night sweats, vaginal dryness, mood swings, brain fog, mental changes, joint pain, and sleep disturbances. What we're also trying to do is prevent bone loss, which we know is either osteopenia, osteoporosis, improve quality of life for women with moderate to severe symptoms. We have the types of hormone therapy. We have either estrogen only, which is for women who've had either a hysterectomy, or if we're using an IUD, we can also just use estrogen only. Combined estrogen therapy is estrogen with progesterone, and that's for women who still have a uterus to protect against endometrial cancer. If women are not using that, they can also use just local estrogen, vaginal estrogen, for treating general urinary symptoms which helps just the vagina. We now know that just using vaginal estrogen also helps prevent urinary tract infections. The forms of estrogen and we use comes in forms of patches or pills or sprays. Vaginal estrogen comes in creams, tablets, and rings. There are also risks and benefits of it, which we discuss in the office. Hormone therapy is not a one-fits-all. It can slightly increase the risk of certain conditions like blood clots, stroke, or breast cancer, depending on the type, the dose, and duration. The decision to start hormone therapy should be individualized based on age, and we know that if you start using it within the first 10 years from the time you miss your period to no more periods, that's the benefit time. We call that the 10-year window. And the decision to start should depend on symptoms and quality of life for personal reasons, and also looking into family and medical history. So we use it, and so that's the key to all of this. So that's hormone therapy. So it's either estrogen alone, estrogen and progesterone, or vaginal estrogen. That's hormone therapy.
Okay. All right. Thank you for that explanation. Really helpful. Okay. Let's turn to our next question now. Dr. Jackson, this one is for you. What are the differences between hormone therapy and bioidentical hormone therapy? And can you talk about the pros and cons for each?
Bioidentical hormones are hormones that have the exact same chemical and molecular structure as hormones that are produced by our bodies. These are available in both FDA approved and non-FDA approved formulations. Very often, bioidentical is used as a marketing term by people who make non-FDA approved formulations of these hormones or compounded formulations of these hormones. But there are FDA approved bioidentical formulations, and this includes estradiol, which comes, like Dr. Fay says, as a tablet. Transdermal could be a patch, a spray, or a gel on your skin, or vaginal. There is micronized progesterone, which is a progesterone pill. And there's testosterone cream, which is FDA approved, although not FDA approved specifically for women. The advantage of using the FDA approved formulations is that they're regulated, and you know exactly the dose that you're getting. They've been studied for safety. The advantages of bioidentical hormones in general is somewhat patient preference. There's a theory that maybe they have less side effects because they're more similar to the hormones that our bodies are making already. And some people believe them to have a better relief of symptoms. There's not a lot of data that bioidentical hormone therapy is any better than synthetic hormone therapy. They really seem to have the same effects.
Okay. All right. Thank you. Okay. Next question here, also along the same lines. Dr. Rapp, this one is for you. So if a patient is interested in hormone therapy, can you talk about where they would begin?
Yeah. So first, obviously, see somebody that is familiar with hormone therapy. We have a whole program now of certified menopause practitioners. Again, as previously mentioned, it's not really one size fits all. So yes, while certainly hormone therapy is one of the options on the table, there are other things that we can discuss as well. Best thing is really to prepare for the visit. Sometimes people find it helpful to bring notes with them. We kind of want to get to know you as well as your history. So if you can kind of have an idea, what kind of symptoms are you having? How long has this been going on? What kinds of things have you tried so far? And really, what are your goals? Also important for us to know is, do you have any medical problems? What other medications do you take? We'll ask about family history of certain cancers, family history of osteoporosis or bone fractures. We also, if it's the first time seeing us, want to make sure you're up to date with all your routine health screening. So we are all gynecologists as well as menopause practitioners. So we're happy to see patients that have another gynecologist that's not familiar, but we're also happy to take on new patients as well. So if you have an idea when your last pap smear, mammogram, bone density was, if you've had any recent blood work done, it's always good to bring that with you to the visit, and especially if it's done outside of the system, to bring some records with you.
Okay. All right. Thank you. And I know you mentioned other options. So my next question here, Lisa, is hormone therapy the most effective option for menopause?
So, hormone therapy is often the most effective treatment for relieving menopausal symptoms, particularly vasomotor symptoms, such as hot flashes, night sweats, vaginal dryness. It's also really effective for mood changes and for sleep disturbances. This is because it's directly replacing the hormones that have been declining, and it's been clinically proven to significantly reduce your menopausal symptoms. We always need to evaluate each patient's individual risks and benefits before prescribing. As part of our program, we have all of our patients fill out a symptom questionnaire, which will allow us to figure out what is most bothersome for you, so we can kind of target our treatment individually. Risk level, as Dr. Fay went through, varies by the type and dose and delivery method. But in general, hormone therapy is considered to be the most effective. It's also really, really good for preventing bone loss, and that is one of the FDA indications for using hormone therapy. There are other options for things that we can use. There are the antidepressants that we sometimes use that work really well for vasomotor symptoms. There's also some medications such as Veoza, which is specifically targeted for menopausal hot flashes. And then there's off-label uses of gabapentin that we sometimes use, or oxybutynin. So there are many options that are available to us. There's also non-pharmacological techniques such as cognitive behavioral therapy. So really what's best is to have an individualized consultation with a menopause provider. So we can go over what's important to you, as well as what your family history is, your own personal medical history, the current medications you're taking, and then we can together come up with a plan that will work best for you.
Okay. All right. Yeah. A custom plan makes sense. So thank you for mentioning that. All right. So circling back here to Dr. Fay, next question here. When do menopause symptoms stop? Are there any natural ways to help with the symptoms?
So menopause symptoms, when they begin and when they end, there's no fixed end date and there's no fixed beginning date. I can tell you, I have a patient who's 74 still having regular periods. It's a bell-shaped curve for everything, just like when you get your first period, when you get your last period. So the same thing with symptoms. Symptoms don't have a fixed date. They're going to widely change in terms of duration, timing, depending on patients. Perimenopausal symptoms can start 4 to 8 years before a period ends. Menopause is only 1 year from the last period. Most people don't know when that's happening. Postmenopause, we all hope, is going to be 1/3 of our lifetime after we stop having periods. So hot flashes, 1 in 3 women may still have them into their 70s. We can use natural things to help with these hot flashes, dressing in layers, avoiding triggers such as spicy foods, alcohol, hot foods, caffeine, deep breathing to reduce the intensity and frequency and to stay hydrated. For moods, sleep, and stress don't help. Yoga, meditation, and mindfulness can help. Cognitive behavioral therapy, which was just discussed, we can help if you can help reducing anxiety, depression. Plant-based remedies such as black cohosh might help a little bit, red clover root, soy isoflavones, evening primrose oil, vitamin E can help with vaginal dryness, omega-3 fatty acids can help mood swings. For vaginal dryness, we talk about vitamin E, we talk about coconut oil, aloe, silicone, water-based moisturizers can help. For mood changes, we talk about, again, decreasing your stress. Duration and severity of symptoms depend on genetics, overall health, lifestyle, and really when menopause begins. The earlier your menopause, they say, the longer your symptoms will last. Hormone therapy and other things can ease the symptoms, as we talk about. Balanced diet, calcium, vitamin D, and limiting your sugar, your caffeine, alcohol, regular exercise. So really different things can help. But it all depends on your genetics and just the luck of the draw, really.
Okay. All right. Thank you. Helpful rundown and some options to consider. So appreciate it. Okay, let's talk a little bit about PCOS. So Dr. Jackson, what are the impacts of hormone therapy in menopause for patients with PCOS?
Patients with PCOS are already dealing with a hormone imbalance. And it's actually been shown that patients with PCOS tend to go into menopause a few years later than people without PCOS. Once they're starting hormone therapy for their menopause symptoms, there's not a lot of differences. Hormone therapy is going to treat their typical menopause symptoms. It won't, however, treat some of their PCOS symptoms that might persist. So signs of having too much testosterone, like acne and hair on your face, or metabolic syndrome that's associated with PCOS, won't resolve with hormone therapy. The other thing to think about for hormone therapy in somebody who has PCOS is the need for endometrial protection. So in anybody who's on hormone therapy who still has their uterus, they need to have some sort of progesterone to protect their uterus. But in people with PCOS, because of their chronic anovulation, they already have an increased risk of endometrial hyperplasia or cancer. So you really want to be aware of that and make sure that they have adequate endometrial protection.
Okay. All right. Thank you. And as a follow-up here, for a patient that has PCOS and having a hard time tracking periods, how can they know when they enter the menopause phase?
It can be super confusing because there's a lot of overlapping symptoms between perimenopause and PCOS. They might be having irregular periods, which we know can be from perimenopause. They might notice mood changes or weight gain. But the big difference with perimenopause is going to be the vasomotor symptoms. So if they start having hot flashes and night sweats, that's not seen with PCOS, and we know that that's from perimenopause. And the definition of menopause would still be the same. So once they got to 12 months without bleeding, we could say that that was menopause, especially if they're having hot flashes and night sweats.
Okay. All right. Dr. Rapp, question for you here. Can menopause go away and come back?
So I think it's important to differentiate between menopause and menopause symptoms. So menopause is really kind of one day. When it's one full year from the last time you had a period, then we say you're officially in menopause. Now, if you do start bleeding again after that, after it's been one full year of no bleeding and you had regular cycles before that, that sometimes is a sign of abnormalities. It can be endometrial cancer or abnormal cells. It's not always that, but that certainly should prompt a workup. Menopause symptoms can be very variable. So they come and they go, especially during perimenopause. You might have a gap in your cycles of several months where you have a lot of symptoms, and then all of a sudden your periods come back monthly and the symptoms go away. And I think that's different than someone that goes through menopause and then all of a sudden 10 years later, if you start having a lot of hot flashes and night sweats, that's not always from menopause. So that's something that deserves another workup. There are certain medications that can cause hot flashes, certain medical conditions, and other things like that.
Okay. All right. Very helpful. Thank you. Okay. Another popular question we received was about menopausal weight gain. So, Lisa, how does estrogen affect GLP-1 weight loss medications? And do GLP-1s work better with an estrogen supplement?
So this is a really great question, and it's an emerging area of interest, especially as more women start to take both hormone therapy and GLP-1 medications like Wegovy, Ozempic, or Mounjaro for metabolic and for weight health. What we know is that estrogen appears to enhance the GLP-1 receptor activity in the brain, particularly in areas that regulate appetite and metabolism. Animal studies have suggested that estrogen also will boost the filling effects of GLP-1, potentially improving the weight loss. Estrogen may also increase our own body's natural production of GLP-1 in the gut. So that would, when you're taking a GLP-1, also kind of boost the effects and increase the amount of weight loss. In menopause, our falling estrogen levels are linked with increased insulin resistance, with abdominal fat, and with appetite changes. And so when our estrogen levels are decreasing, those are all factors that can help like blunt the effects of a GLP-1 that you're taking. And so for those patients who are on GLP-1s and have really good effects for a while, and then are not at their maintenance plateau, but just stop losing weight, sometimes adding some estrogen could be considered to help boost the GLP-1 effects. But again, in theory, estrogen can improve how well GLP-1 medications work, but we do not have enough research to confirm this. We need a lot more research in women's health in general, but specifically in this area with the GLP-1s being a newer class of medications that are being used, there's just so much more research that needs to be done before we know for sure. But there's no large-scale human trials right now yet that are proving that estrogen will directly boost the weight loss from a GLP-1. But for postmenopausal women with symptoms, adding menopausal estrogen therapy could offer indirect benefits. It can help improve energy and sleep and metabolism, which can all support better results on the GLP-1.
Okay. All right. Interesting. And thanks for letting us know there. Okay, Dr. Fay, we will turn to you. Keeping along the same lines of weight gain, are there any supplements postmenopausal women can take to reduce that menopausal weight gain?
This is probably one of the most frustrating areas that we all deal with, because patients come in all the time, weight gain, postmenopausal. So evidence shows that men and women actually gain fat roughly at the same rate in their 40s and 50s. But everybody comes in, everybody complains of weight gain postmenopausal. Body fat does respond to changes in sex hormones, which typically affects how well fat is used for energy and where fat is distributed. As with other issues, adipose tissue has receptors for estrogen, progesterone, and androgens. After menopause, testosterone from the blood is converted via aromatase into estradiol in the adipose tissue. So during menopause, estradiol and progesterone levels go down, FSH goes up. Women often notice more fat accumulating, and often it's new places, such as the midsection. And everybody comes in, they complain about it. As the FSH increases, it tends to increase the weight, and fat gain inhibits thermogenesis, and fat accumulation occurs. Leptin and ghrelin are the two other hormones that are linked to fat. Leptin acts as a suppressant. Ghrelin acts as a stimulant. Increased fat in the body causes leptin resistance, which means that the normal signals are totally disrupted. Poor sleep is one of the big things everybody has during menopause, and it increases the ghrelin, and that way we're hungry. Our leptin is a problem. Menopause increases anabolic resistance, and we lose muscle mass, and that's why it doesn't matter how much everybody exercises, their weight is bad, and we get that testosterone levels drop, and therefore we have poor muscle mass, we have that growth, we have that less growth of muscle mass. So managing menopausal gain is such a common concern, and supplements are not the magic fix. And so I don't know if everybody should be on GLP-1, who knows? But it's menopausal hormone therapy is also not the thing that's going to help. So, but they can support metabolism with some of the supplements, because that can help reduce inflammation. Mediterranean diet can help. Vitamin D and calcium can help support bone and help reduce some of the fat accumulation. Omega-3 fatty acids can reduce the inflammation, support heart health, and regulate metabolism. Green tea extract can mildly boost metabolism and fat oxidation. Protein powder can maintain lean body mass. Magnesium can regulate blood sugar, also help with sleep. reduce bloating, and probiotics can also help with gut health. But God help us. There's such a problem with weight gain in menopause. I wish there was an answer. I wish there was a cure. I wish there was something we could tell people that actually would really be the answer. We have none. So all we can do is help support everybody with helping change their diet, help with inflammation, help with sleep, and just all work it out together. I wish there was an answer. I really do. But this is with all the research that I could come up with.
Well, thank you. And I think that it's helpful to, not only hear that, but also be able to have this open discussion to know that, you're not alone, that this is something.
You're not alone. Absolutely. But there's a good reason for that mid-center belly fat, no matter whether everybody exercises 5 to 6 days a week, watches their diet and everything else. There's a good reason for it. Nobody, unfortunately, is going to look like their beautiful 22-year-old daughter. It's true. And I wish we could say we'd all look like that again.
Well, thank you. All right, Dr. Jackson, we will turn to you. So another question here, does hormone medication make you gain weight?
So it's interesting. If we use different versions of progesterone in higher doses, that certainly can make you gain weight. I think Dr. Fay did a very good job explaining why we gain weight in menopause. And no, taking hormone therapy for menopause does not make people gain weight. There's some thought that it might help you lose weight, although it is no magic cure, but by getting rid of the hot flashes, getting rid of the sleep disturbances and mood changes, it might make it easier to make lifestyle changes that is really going to be what helps with the weight loss.
All right, thank you. Okay, Dr. Rapp, turning to you now. I know we talked a little bit about perimenopause and menopause. So can you just talk to us about the difference between the two and how do you know when you're in each?
Sure. So again, that strict definition of menopause is no bleeding for 1 year, but the process from moving from perimenopause into menopause is really a continuum. In addition, not everybody has that clue of when they have the last period. So if you've had a hysterectomy, if you have a progestin IUD, if you've had an endometrial ablation, you don't always know. But honestly, we treat them pretty similarly. So it really is more based on what your symptoms are, and we try to tailor the treatment more towards your symptoms. So the symptoms can be a little different. Perimenopause symptoms can start as early as your late 30s, although some people don't notice anything at all. What's happening in perimenopause is the normal changes that we're giving you a menstrual cycle get a lot more erratic. So kind of higher highs and lower lows and just some more irregularity. And so that's what can cause some of those mood symptoms, breast tenderness, irregular cycles, and sleep changes. Really, once those periods stop, the further you get from that last period, a lot of the symptoms you have are more lack of estrogen. So that's more of the vaginal dryness, the bone loss, and again, as others have mentioned, you can still keep some of those vasomotor symptoms, the hot flashes and night sweats in some women up to 20 years.
Okay. All right. Thank you. Okay, Lisa, turning to you now, a topic that I'm sure a lot of people are struggling with, sleep. So can anything be done about insomnia and the bad sleep that comes with menopause?
So disrupted sleep is a very common symptom in perimenopause and menopause. There's a multitude of reasons why this happens. Hot flashes and night sweats can wake you up. In addition, just your declining estrogen levels and progesterone levels, they also affect your serotonin and your own melatonin levels that you make. That in turn impacts your mood and your sleep cycles. And so there's kind of all of these things that go into it. And just in general, we know just from the population aging itself contributes to lighter, more fragmented sleep. Many menopause treatments can help with insomnia. Hormone therapy can help by decreasing your hot flashes and your night sweats. And so therefore, they're not bothering you at night and they're not waking you up. It can also help improve your serotonin and your melatonin levels so that your body is just naturally regulating itself to sleep better. certain antidepressants like that we use for menopausal treatment, also, if they're fixing the hot flashes, they would do the same thing. So that can help with your sleep. Gabapentin is commonly prescribed for hot flashes. It also has a mildly sedating effect, and so that is helpful. If you go to cognitive behavioral therapy, that can help retrain your brain to fall asleep and stay asleep. That method is really, really effective, more effective than a lot of sleep aids. The other thing that is really we need to focus on in this period of our life is sleep hygiene. We cannot overstate how important good sleep hygiene is for helping us get a good night's rest. These are things like avoiding all sorts of electronics for 2 hours before you go to bed, having a nice cool bedroom temperature, having moisture wicking sheets on your bed, sleeping with a fan on, both for the comfort of making you cooler and also for the white noise benefit. Having a consistent bedtime routine is really important. There's a reason that we do this for our children when they're young and we're trying to get them to sleep on a good schedule. It's because going through this routine and doing the same thing every night will tell your body it is time for me to go to sleep. And so what I usually tell my patients is it's really important to make sure that you have some sort of bedtime routine where you are relaxing in the evening, you wash your face, you brush your teeth, you get into bed, you read a little bit, just avoiding electronics. And, it's also important just not to be hanging out in our bedrooms. Like our bedrooms are there for sleep and they're there for sex, and they are really not there for watching TV or spending time in the afternoon. Because when you get into that habit, then your body stops associating your bedroom with the time to go to sleep. So there's lots of things that we can do, but importantly, what is often overlooked by women who are complaining about their trouble sleeping in menopause is sleep apnea. So if we try these things and it's not working, you need to get a sleep study, because the rate of sleep apnea is very high. A lot of people don't realize that they have it. And if we correct the sleep apnea, you can sleep at night. So try these routines, try to, have your consistent bedtime routine and to get plenty of water and to, sleep in a nice cool bedroom. But if that's not helping, get a sleep study.
Okay, very helpful tip. Yeah, the sleep study especially. So thank you for calling that out. All right. Okay, Dr. Faye, know we've been talking a lot about mood swings, hot flashes, night sweats. It's been coming up a lot so far in our discussion tonight. So what can help alleviate these issues? And are there medications or natural remedies that could help?
So we've done a lot of talking about all of the hormone therapy that can help. We've talked about gabapentin, we've talked about oxybutynin, we've talked about Veoza. So some of the hormone-free that have been backed by varying levels of scientific evidence are black cohosh, soy, evening primrose oil, mind-body practices like yoga, tai chi, meditation, deep breathing. Some of these things can be helpful. Cognitive behavioral therapy, diet, lifestyle changes, which we've already talked about. We've talked about eating the Mediterranean diet. We've talked about things like magnesium for mood regulation. Also, that helps with sleep. Vitamin B6 helps with serotonin production. Some herbs we talk about, but again, some of the herbs you really have to be careful of. So I always tell patients, if they're going to buy something, don't buy something that says menopause, because if you're going to have a reaction to it, you don't know what you're going to have a reaction to. You don't know what's in it, if it's going to have different things, because we have ashwagandha, we have maca root, we have things, the valerian root, chamomile. If you're going to have a reaction to something, you don't know what it's going to be. So buy something that's only one supplement rather than a multitude, because you really don't know if it's, if there's something in it that could be bad for you. And so I'd rather you get something that might be one thing that could improve maybe something, rather than something that has all these other things in it that could be bad, because black licorice isn't good for your liver. There's certain things that we have discovered over time that aren't good. So just try one thing. Again, sleep support, which was gone over so beautifully before, all these things can kind of help. So if people prefer not to use hormone therapy, can't use hormone therapy, have tried some of the non-hormonal things like Veoza, can't use it because of liver problems or kidney problems, can't use it. Some of these things can be helpful.
Okay. All right. Thank you. Okay, a few more questions here, and then we will get to the live questions from the audience. Know there are questions coming through, so thank you. Feel free to submit any other questions you might have, and we will get to those in just a bit. But for now, Dr. Jackson, I will turn to you here. Can vaginal estrogen cream be used without getting yeast infections?
Absolutely. I would say most people who use vaginal estrogen cream don't get yeast infections. We know that very high levels of estrogen, like when somebody is pregnant, can increase their chances of yeast infections. The amount of estrogen when we use vaginal estrogen is still low dose estrogen and usually won't cause yeast infections. The vaginal estrogen cream is usually covered by insurance and relatively easy to obtain. And a lot of times it's the first vaginal estrogen treatment. But there are other formulations for people who aren't comfortable using a cream for any reason. And vaginal estrogen can come in a vaginal tablet, a ring that goes in the vagina and stays in for 3 months at a time, and a soft gel ovule that people put in with their fingers. So there are some options for people who don't want to use a cream.
Okay. All right. Good news. Thank you. Okay. Dr. Rapp, this next question is for you. Is the estradiol patch cream safe for women who have family history of stroke?
Yeah, so I like this question. I think it brings up a lot of good issues and things that we can talk about. One, in general, estradiol is very safe. So, the estradiol that we use for hormone therapy, you heard Dr. Jackson mention that it's similar to the estrogen that we produce, whether we call that bioidentical or not. But when you're pregnant, your estradiol levels are up in the thousands. So even with hormone therapy, it's rare to see it above 200. So this is something your body's been exposed to before in your lifetime, typically without a problem. Another thing that's important is the route of administration. So there's something called transdermal, which means through the skin. So we've alluded to a little bit of this, but there's patches, there's sprays, there's gels. Those are all transdermal, which is different from an oral estrogen. Okay, not that oral estrogen is unsafe, but oral estrogen goes through the digestive tract, goes through your liver, and in your liver, it can stimulate the production of some clotting factors. The transdermal gets absorbed directly into the bloodstream, so it does not go through your liver and does not increase your risk for clotting factors. So if you're someone that has a higher risk of blood clots, that can be from smoking, from obesity, from certain genetic mutations or family history, that's a time that I would recommend the transdermal, over the oral. And then finally, although your family's history is important, it's not really the be all and end all when making your own medical decisions. So often what's in the family is not a contraindication, and that applies to things like stroke, heart disease, or breast cancer, is still not something that necessarily makes the decision for you yourself.
Okay. All right. Thank you. Okay, Lisa, next question for you here. What can one do for inflammation and joint pain after surgical menopause?
So this is a good question, and I think it requires us first to define what surgical menopause is. So surgical menopause is the removal of your ovaries. Removing your uterus during a hysterectomy, although it makes you stop getting periods, and so you technically will meet the definition of menopause because you're not getting a period anymore. It doesn't stop your ovaries from working. And menopause really is when our estrogen and progesterone level are very, very low because the production of estrogen and progesterone from our ovaries ceases. And so that's a common area of confusion for a lot of people because a lot of people think, oh, I've had a hysterectomy, I don't have my ovaries anymore. But most of the time when we do a hysterectomy, we leave ovaries in place. But when someone does have removal of their ovaries and they end up in surgical menopause, sometimes they get very severe symptoms. And that is just because it's a sudden and steep decline in your estrogen and progesterone levels. Whereas when women go through this naturally, you have the benefit of, days when your estrogen and progesterone are really high and then they're low. And, your body kind of gets used to the fluctuations and it's not just a sudden removal. But when you do have those ovaries removed and you do have that sudden and steep decline in estrogen and progesterone, it can cause inflammation, joint pain, and stiffness. And those are common things that we see that a lot of people are not prepared for before surgery. Estrogen therapy can help reduce the systemic inflammation and relieve the joint discomfort. Benefits are especially strong if they're started soon after surgery and you're under the age of 60. There are other things beyond, just hormone therapy, though, that is necessary for these joint and muscle issues. You should make sure that you're eating an anti-inflammatory diet, including lots of foods like berries, leafy greens, olive oil, salmon. Dr. Fay did a wonderful job talking through an anti-inflammatory diet earlier. But those things will help kind of decrease the inflammation in your body because of this sudden change in your hormone levels. Low impact exercise also will be really helpful to help reduce stiffness. And it's important that we incorporate resistance training anytime that our estrogen and progesterone levels are decreasing, because that helps preserve our muscle mass and it also helps with our bone strength. So those are important things that, we want women to be doing when they go through this transition. So definitely we consider hormone therapy. You should, for most people, be on some form of hormone therapy after removal of your ovaries, as long as it's not for a cancerous reason that we're removing them. We also sometimes, instead of just using estrogen, we add in the micronized progesterone. That's also helps with our anti-inflammatory response.
All right. Thank you. That was incredibly helpful. Thank you for walking us through that. And now here for the last submitted question, I will turn to Dr. Fay, and then we can jump into the live questions from the audience. Okay, so our last question here before we go to the Q&A, Dr. Fay, is pelvic floor rehab good for menopause and preparing for menopause?
Absolutely. I adore pelvic floor physical therapists. I suggest pelvic floor physical therapists for OB patients and for everyone. It's a powerful, non-invasive option for women dealing with issues like vaginal dryness, pelvic pain, painful sex, urinary incontinence, pelvic organ prolapse, and any issue pertaining to prior, during, after menopause where lower estrogen is there. Thinning of vaginal tissue, loss of muscle tone and elasticity in the pelvic floor, reduced blood flow, lubrication and collagen, increased urinary urgency, frequency, leakage, and pelvic pain and discomfort during sex. They are absolutely wonderful, and they're a help to all of us. So I agree, absolutely, they are wonderful. And every one of us should have them on speed dial. They are terrific, and they have been such a help. I've been using them for like 25 years for my patients. So absolutely, everyone should not be concerned with them doing internal exams on you. They know what they're doing. They're wonderful, absolutely. And as a sexual health person who does, a sexual counseling, I send patients to them all the time. So it's for my sexual health patients and for my menopause patients. So absolutely, I agree. I'm glad this question came up. Absolutely.
Yeah, amazing. All right. Okay. Well, with that, let's get to our live questions. So I will go ahead and just read through the questions. Again, open conversation, so feel free to chime in whenever you feel so, but I'll direct questions as we see fit. So let's dive into it. Okay, first question here, Dr. Fay, I will turn back to you. What menopause and symptom treatment options are available for women who have had cancer? Are options limited?
So for our patients who are having dyspareunia, pelvic pain, we used to never offer them vaginal estrogen. But now we know that we can safely use vaginal estrogen with our patients because study after study shows that vaginal estrogen can be safely used with patients with cancer. And it has come up more often where I have patients coming in who are being sent to me with cancer because they're having had either a gynecologic cancer or breast cancer or lung cancer or whatever. And it's mostly breast cancer patients coming in now who are finally saying to their breast cancer doctor, I need help vaginally, because they're now coming in and finally saying, I'm a woman and I still want to have sex. And thank God. I've done a lot of talks with my breast cancer doctors and have said, before you even start treating these women for their breast cancer, please remember these women need to be talked to about the fact that they are not just cancer patients, but they are full-fledged women and they are still sexual beings, and talk to them. And we thank God they're now listening and understanding that these women still deserve sexual lives. And we can safely use vaginal estrogen in these patients.
All right. An incredibly important conversation. So
yeah. And I've done webinars with a lot of universities and have talked to a lot of, and have had to try to convince, and you might sometimes have to fight with the oncologists, but you have to show them the newest statistics and show them that the vaginal estrogen is not raising the blood very much, and it drops so low that it has not been shown to increase their breast cancer risk or their breast cancer recurrence. And you have study after study to show it. So it's wonderful.
Okay. All right.
These women deserve lives.
Absolutely. Yeah. And thank you for whoever submitted that question. That was a great one. Okay. Next one here. Lisa, can you talk about symptoms of low testosterone and how you know if you would need testosterone as part of hormone therapy?
So symptoms of low testosterone, women do make testosterone in addition to making estrogen and progesterone. And actually, our testosterone production does not decrease as much during menopause as our estrogen and progesterone levels decrease. So testosterone levels stay pretty steady for a lot of people. One area that we sort of look at testosterone levels is when someone is having some sexual dysfunction. And so we do have studies that show in some women that topical testosterone or injectable testosterone will help increase their libido and their sexual satisfaction. Generally, we try to do topical testosterone for most patients. We would check their testosterone levels and their levels at their sex hormone binding globulin before starting to make sure that they're not too high. And we have to just be aware that adding testosterone can cause some side effects like acne, increased facial hair, and it can cause a permanent deepening of the voice. That does not go back even after stopping the testosterone. So that's something important to talk about with people beforehand. But in general, if you're not responding to the testosterone treatment within the first 6 months, it's probably not going to help your sexual disorder. And then we would refer you for other options. Dr. Faye is our sexual health expert. So I don't know if you have anything to add to my answer, Dr. Faye.
So actually, you lose more testosterone than your estrogen and progesterone. Your testosterone drops further than either estrogen or progesterone. And I would never use an injectable testosterone on anyone because the studies actually show that we really don't. The only people that I use injectable testosterone on are my trans. Those are the only people because safety-wise, we worry more about, we don't know the studies yet really for breast and for heart. But the thing is, we only use a tenth of the dose. And really, in terms of the studies now, I really I really do offer a lot of people testosterone. And, I use a baseline testosterone only so that I know where people start, because we don't have an idea in terms of, if somebody has a low testosterone or a high testosterone in the normal range, testosterone levels are just to tell me where I'm starting, because testosterone really doesn't tell you if you're higher in the normal range, like what's wrong with you, you should have a high libido, right? Because it really doesn't tell you how you feel, right? Because we are thinking people. So your testosterone level doesn't tell you anything about, what your real libido is. So I'm really gung-ho about using testosterone, because testosterone really, there's so many women out there who really deserve more in terms of their sexuality and everything else. So I'm really a proponent of it, but I don't start testosterone right away. I really will, first start off with estrogen and progesterone and see how they are, because a lot of times when people come in and they're talking about low libido, a lot of times it's really because they're in pain, right? Because if their vaginal dryness and everything else, and usually you can help them out more with just the fact that if you give them their estrogen and progesterone by way of their hormone therapy, and you give them vaginal estrogen, then their libido will actually increase, right? Because a lot of times it's really just the fact that they're having dyspareunia and they just are having hot flashes and night sweats. And who the hell wants somebody grabbing them and touching them and and climbing all over them, or with their partner, or being even intimate with themselves, right? Because of everything else going on. But really, with ISHWISH, which is the International Society of Sexual Health for Women, and some of my other societies, we really have felt that now is the time to really start offering testosterone more often to women, because of the fact that they really deserve it. And majority of women, it's probably, as you said, Lisa, probably half will do well. And if, as you said, it gives people about 6 months, and half of them will be good on it, half of them won't. And you're right, because if they don't in the first 6 months, if they feel nothing, you take them off of it. But I'm trying to at least offer a lot of them the option. And some of them will actually say, it didn't do anything. But since I'm only giving them 1/10 of a male dose, hopefully they're not getting that acne, the hair loss, or the clitoromegaly, because you're only giving them about 1/10 of the dose. So hopefully we're not getting any of that, the male side effects at all. But I am trying to offer as many people as I can it's the option, because of the fact that since the testosterone is really taking a hit when we go through menopause, so we're trying to offer as many people as we can that option if they want to do it. If they don't, it's perfectly fine. So we're trying and seeing, because, there's 26 medications for men for decreased libido. We have nothing for postmenopausal women. It's awful. And why is it that we can't be sexual beings postmenopausal? Why don't we have anything out there for us? So at least we're trying. And maybe one day we'll have an option.
Thank you. Yeah, absolutely. All right. Next question here. Dr. Jackson, I will turn to you. Is there any information on hormone therapy increasing the nausea side effects of the GLP-1s?
Lisa has probably done the most research about this of any of us. I would think that if you were using transdermal estrogen, there really wouldn't be a change in the nausea, but I don't know, Lisa, in your research about GLP-1s, if you saw anything about that.
Yeah, I didn't see anything about it increasing the side effects. We do know that with GLP-1s, because it does have some delayed gastric emptying, that oral estrogen sometimes you end up with more side effects. But with transdermal, because it's a steady state dose and it's absorbed not through your digestive system, I don't think that there would be an issue with that that I know of.
All right, thank you. Okay, next question here. Dr. Rapp, I will direct this to you, but whoever wants to jump in, feel free. This is another GLP-1 question. So this person asked, for patients that can't use GLP-1s due to intestinal issues, are there any other options?
I mean, and I assume they mean options for weight loss. So again, and some of this has been covered, there are lifestyle things we recommend: getting enough protein, getting enough fiber. We talk about the importance of, with when you're exercising, it's not just the cardio you want to do. You want to do strength training and things to maintain your muscle mass. We don't, in general, prescribe the GLP-1s. There is a weight management center through Abington. I know there are oral medications that they use. I think one of those is metformin. There are some other ones. So there are some non-GLP-1 oral medications that have been used for weight loss as well.
Okay. All right. Thank you. Okay. Next question here. Lisa, I'll direct this to you, but again, whoever wants to jump in, feel free. This person says, I've been wearing an estrogen patch for 20 years and am still experiencing hot flashes. Is this normal to have menopause symptoms for this long?
Dr. Faye covered this a little earlier whenever she first was talking, but the transition for some women, it's an individual experience. And so some people experience no symptoms at all, and some people have symptoms for a very long time. And so, when we have patients who we are started on therapy and, and it's helping, but it's not completely resolving the issue, it is important that we kind of look into other things, make sure that, their thyroid is fine, like kind of do a full body in-depth looking to see, like, not all hot flashes are caused by menopause. Although menopause causes a lot of hot flashes, there are other things that it could be. And so I think it would be important to kind of have a thorough workup to make sure that there's not something else going on that's being missed.
And if it's okay, I'll chime in for a second. We all don't often recommend doing blood work or blood tests to assess things like estrogen levels. But if you're someone that's on a patch and you're on a reasonable dose of a patch and you're still having hot flashes, that's sometimes a role where we would do a blood level to make sure that it's getting absorbed appropriately. Not everybody absorbs medication the same way.
Okay. All right. Important to keep in mind. Thank you. Okay. Next question here, Dr. Faye. When should you have your estrogen level checked?
I don't check estrogen levels. So, I don't know. I think that if somebody has had an endometrial ablation or somebody's had a hysterectomy or something like that, and I guess they want to know that I don't do an estrogen level. So I don't know. Because if somebody comes into my office, they have had lab work done and they said, these are my labs. I actually am a talker. So I ask them how they're feeling and, when was your last period? What are your symptoms? I'm more interested in how they feel, because somebody can come in with all of their labs, their FSH, their, all these labs. 3 different people can have the same labs, but one person can feel fine, one person could have some symptoms, one person can feel awful. A lab result is not going to tell you how somebody feels. And so we now do hormone therapy for quality of life. We don't put somebody on hormones just because they're menopausal. So you want to know how they're feeling. So it's not like knowing there's cholesterol. So I don't do lab work to know that somebody's menopausal. Somebody's perimenopausal based on their age, but that's not the thing. It's like, are you having periods or are you not having periods? Are you having regular periods? Are you having irregular periods? How do you feel? Are you having hot flashes? Are you having brain fog? How's your quality of life? It's more, talk to me. I'm going to ask them questions. We're going to go through symptoms. So I don't roll blood levels just to know what's going on, because that blood level doesn't tell me what's going on with the person.
Yeah, I agree completely with Dr. Faye. And I was just going to add, the other problem is in perimenopause, your estrogen and all of your hormone levels fluctuate so much that if we were to check it, we would just get that one moment in time. That wouldn't tell us the whole story.
It doesn't tell you anything about anything. Yeah.
All right. Definitely important to keep in mind. Thank you both. Okay, next question here. Dr. Faye, I'll go back to you on this. I know we just kind of covered it, but anything else you'd like to add, as we did have this question come in? This person says, how about lack of libido? How does this come into play during this time? And are there any options to aid in this?
Well, sure. But I mean, as a sex counselor, I'm going to talk to you because I want to know more than just, you know, how do you define libido? I mean, was your libido always down? Did it just happen? How was your relationship? How did you grow up? Did you grow up in a family in which your parents showed, you know, not that they showed themselves on a couch, but did they show love and affection? You know, was there expression? You know, so I go through more than just, you know, okay, your libido's down. Let's hand out drugs. So, you know, I go through a lot more than just, so, you know, do you have painful sex? You know, what's the relationship? I go through, you know, it's not just the bedroom. It's how is your relationship, you know, in the kitchen? What is your relationship like with your partner? You know, what does he help around the house? What is your life like? You know, so you go through a lot more. So, you know, we do a lot more talking. I'm a talker, obviously. So you know, with my hands and everything else. So you have to do a lot more when you're talking to somebody because everybody's definition of libido is different. And, you know, you want to know, when did it start? Did it just change? Is this new and different? You know, there's a lot more to it. So we do a lot of talking.
Okay. All right. Thank you. Okay. Next question here, Dr. Rapp, I will turn to you for this one. How do providers determine the best hormone therapy for a patient who has been on continuous birth control pill for several years?
Yeah, so that's a great question. Most women will go through menopause around 51 to 52. So a lot of it is how old is the patient? What kind of symptoms are they having? Some people will get menopause symptoms even on birth control pills. Some people feel wonderful on birth control pills. A lot of times, if you hear from your peer group, you know, everyone's having crazy bleeding. You know, one of the nice things about being on birth control pills, it's often not just helping with symptoms, it's controlling bleeding, and it's also providing contraception. So sometimes people assume as I'm getting older, I'm still not fertile, but you really, you know, if you're still having periods every month, there is still a chance of pregnancy. So it's actually a really good option to both control symptoms, control bleeding, and provide contraception. Typically, when somebody is like 51, 52, kind of every year we'll have that conversation. You know, one option is at some point to have them stop and see what happens, you know, and that's one way to see, are they still having periods or not? Another is if they're afraid to get symptoms come back, we can talk about transitioning directly to hormone therapy. So again, I think a lot of this is really individualized, you know, and some of that depends. If somebody's been on birth control pills to control their bleeding and their partner has a vasectomy, then it's certainly an earlier age that we might talk about hormone therapy. If that's kind of what they're using for contraception, I'm a little more likely to keep that on for longer.
Okay. All right. Thank you. Okay. Next question here. I'm not going to direct this to anyone. I'll open it up to the group. So whoever wants to jump in. How long should or could BHRT be used? Is there a specific time when you should stop? Dr. Fay, I see you nodding or shaking your head.
You can die on hormone therapy as long as you start it when you're supposed to, if you start it when you did, which was within that 10-year window, you can stay on it for life. So
right. Unless you develop a contraindication. So if you're on hormone therapy and you develop a blood clot in your leg or your lung, we're going to tell you it's time to stop. But if everything is all good and healthy, there's actually been studies recently showing better longevity outcomes in women on hormone therapy.
Absolutely. And the same thing with vaginal estrogen.
I think that some people who don't want to take it forever, what's a little bit confusing is you won't necessarily know when you don't need it for symptom control anymore because you're feeling good on it. So sometimes I'll have people periodically try to come off of it and see if they have any symptoms. And if they feel fine off of it, sometimes they'll choose to stay off of it. And that's okay too.
Yeah, I have the 80-year-olds who are saying to me that if you take my estrogen away from me, they'll slit my throats because they're the ones who are walking in the high heels and the scarves and, you know, the matching bra and underwear sets. So they're walking into my office looking so great that they just say, I'm staying on it forever, you know, and I just go, you go there, you know, you do it. And they look wonderful. And, you know, they look so great. Their skin looks gorgeous. They're not going off of it. And they were the same women when the WHI was saying, quote unquote, they should go off of it. They were telling me then they weren't going off of it. And they were all right.
All right. Thank you. All right. Next question here. What about hair loss during menopause? Any tips or treatment options? And again, I'm going to open this up to the group.
This is a really tough one. Your hair just naturally goes through times where your hair is fuller and then you experience periods of hair loss. And certainly during hormonal fluctuations that can happen. We see it a lot in the postpartum period after women have a baby and they have that decline in hormones. There's a lot of shedding of hair. And in general, we are concerned if it's a progressive thing that continues happening. But there's, often it's a temporary thing and it starts to get better. Dermatology is very good about, having some topical solutions that you can try. If a person is really interested in trying some biotin to help with it, I'm not opposed to them trying that for a period of time and seeing how that works.
And minoxidil and spirulactone together, the combination studies show using the combination together is good. And checking their thyroid, because it's the most underdiagnosed disease of women, right? So sometimes it's just damn old genetics. Because you say, what was your mom like? And they go, come to think of it, my mom had thinning hair. And so sometimes it is just genetics too.
Those darn genetics, yeah.
Yeah, you got those genes, your Levi's are just, that's what you are. You have them.
All right. Okay. Next question here. So again, I'm going to open it to the group. This person says, I've seen a lot of buzz on social media about the use of creatine to help support women going through the menopause transition for maintaining muscle and for its cognitive effects. And this person would like to know, what's your opinion on the use of creatine supplements?
I know it's really promoted on social media, but it really doesn't have the data behind it.
Right.
And I hate to say it, but I think, if somebody is selling something to you, you have to be a little bit suspicious.
Absolutely.
But it really doesn't have the data behind it.
Yeah, it doesn't.
All right. Something to think about for people. Thank you. Okay. Next question here. Is there a difference between menopause and post-menopause?
Yeah, menopause, as it was Sandy who said it, menopause is 1 year. Post-menopause is the rest of your life. Hopefully it'll be a third of your life. But when we traditionally talk about menopause, we're talking about 1 year. And then we're talking about post-menopause.
Okay, thank you. All right. Next question here. Dr. Jackson, I'll direct this to you. And I know we, again, talked a little bit about it, but if you have any other thoughts, I think, Lisa, you may have covered this too. But this person wants to know what can be done for severe fatigue.
I think it's really sort of looking at what's causing it. Is the severe fatigue due to insomnia, or is it somebody who's sleeping and still feeling very tired? Dr. Fay had mentioned checking thyroid levels. It's another time that you'd really want to make sure that there's not something else going on like hypothyroidism. And then really looking at sleep and what we can do to maximize sleep. There's a lot of also not so much overwhelming fatigue, but just low energy that goes along with menopause. And sometimes that's better with hormone therapy with estrogen and progesterone. And sometimes, especially if it's also associated with low libido, sometimes that's something that testosterone can help. So yeah, I think there's a few different things to look at. Like everything we've talked about tonight, I think is very individualized and would need a conversation with your provider.
Absolutely. Okay. All right. A few more questions here, and then I think we'll wrap up for the evening. This next question, how likely is it that menopause symptoms will continue when women are postmenopausal after they have been period-free for a year? No, we discussed this a bit, but I think this person would like to know a little bit more here. If they often do continue, is there an average for how long?
It's hard because it's so different for every person. Although most
Right.
people won't have symptoms more than 5 years from their final menstrual period, but a lot still will.
Mhm.
All right.
Yeah.
Okay. I'm going through the questions here. I think this might be our last one. This is a specific one. What dosage of magnesium and or B6 would you recommend to start with?
400 milligrams of magnesium, well, of magnesium, 400, because remember, magnesium, like milk of magnesia, if you take too much of it, you're never going to get off the toilet. So you got to watch what you're taking. So like mag oxide, if you take too much of it. So if you're somebody who tends to have loose stools, you better watch it.
All right. Okay. Um,
Sarah, if I'm going to, I saw one more question, which now I don't see anymore, but it was about other non-hormonal options for vaginal dryness. And I thought that was something that we hadn't really covered yet. So there are a lot of good over-the-counter options that you don't need a prescription for. A lot of them are hyaluronic acid based. So a variety of different brands. I should say some, but one's called Reverie. There's one called Hyalogen. They have ones that are creams. They have ones that are inserts. There's something called Replens. All of those are things that you can use that can help with vaginal moisture and dryness that you don't need a prescription for, that are readily available.
Just make sure that they are pH balanced. If you're going to use something that's going to be water-based, if it's not going to be hyaluronic acid too, if it's a water-based thing.
Okay. All
I
right.
think it was mentioned briefly, but coconut oil is something else that's very moisturizing for the vagina and
Yeah,
safe.
coconut oil. Yeah.
Okay. Very helpful. Thank you.
Or
Okay.
even aloe.
Aloe, coconut oil.
Yep.
Keep that in mind. Okay, thank you. One other question here, and then I think I'll wrap it up for the evening, unless you all have spotted anything else. And again, we might be repeating ourselves a little bit here, but think it's helpful to go through just talking a little bit more about the side effects of hormone therapy.
Yeah,
So if
so
anyone,
typically when we start somebody on combination estrogen and progesterone, I'd kind of address them individually. So estrogen for some women can cause breast tenderness. There are a lot of different options as far as doses of estrogen for many women. And again, this is a conversation. We talk about starting probably somewhere around the middle. There are some reasons we would go up, other reasons we would go down. One is if they're having a lot of significant breast tenderness. Another thing is if you're closer, either late perimenopause or early menopause, you can sometimes get some irregular bleeding. So even if you hadn't had bleeding for a while, you have a uterus, it works, it responds to estrogen and progesterone. So especially in those first few months, there's a bit of an adjustment period. So certainly as you're getting further out or you've been on it for a long time, if you develop bleeding, that's something that needs a conversation and an evaluation. But those first few months, it's not uncommon to see some irregular bleeding. And then as far as the progesterone, a lot of times we'll use micronized progesterone, which is a natural progesterone. For some women, it makes them feel great. They sleep well, they feel good on it. They feel relaxed. Other people, it just doesn't work well for them. And they get more GI side effects. They can get moodiness. They get bloated. So it's the same thing. It's just not a one size fits all for each medication.
so again, have a conversation with your doctor, it sounds like. So, okay. Perfect. All right. Well, thank you all. I think with that, I'm going to go ahead and ask my final question for the evening. And that is, what are your goals for everyone listening in on this webinar? What would you like our viewers to take away from tonight? So, Dr. Fay, we will go ahead and start with you.
I want people just to understand a little bit more about menopause. Also, that you can find people who understand menopause, that people go find people who will validate your feelings, who will validate your questions, who are willing to listen to you, understand you, and just find practitioners who will talk to you. There are people out there. There are people who are certified menopause practitioners, and we're willing to help you. So find us and, go to people who will be here for you. Okay. There are people out there for you. Don't be afraid to ask questions, and don't be afraid to find people who will help you. because people are willing to help. Don't suffer in silence.
Yes, absolutely. Thank you. Okay, Dr. Jackson, any final remarks?
That menopause is a very natural process and it's hopefully going to happen to all of us. And everybody's experience with it is very different. Some people have very minimal symptoms. They're super lucky. And some people are very uncomfortable with the symptoms. And I think it's important just to sort of look at your own experience, your own symptoms, and the things that are most important to you. And then, come see us. Like Dr. Fay said, there's a lot of menopause certified practitioners who will talk to you about your symptoms and your goals and the best treatment for you as an individual.
Right. Thank you. And Dr. Rapp.
I think similar to what others have said, people with the same constellation of symptoms might opt to treat them differently or not at all. So you really want to find someone that's going to discuss all the options, but there really is not one right answer. It's really what works best for you. And there's a little bit of trial and error. Sometimes we start with one thing, we see how that's going, and we need to make some tweaks, or whether we need to add something, take something away. There's a kind of an evolution.
Okay. All right. Thank you. And last but not least, Lisa.
So I think what I would like is, even if you're not interested in hormone therapy per se, find someone when you're going through the menopausal transition, find some as menopause certified provider to talk to. There's lots of non-hormonal treatments that are available, and it's just good to have a community where you're able to kind of talk about your symptoms, know what's normal, know what's not normal, and and just learn about all of the health changes that happen during menopause so that you can optimize your later life, so that you can live a long and healthy life.
Absolutely. I think that's a great note to end on, and definitely what everyone is doing attending this webinar. So thank you all. Well, thank you so much, Dr. Fay, Dr. Jackson, Dr. Rapp, and Lisa, for your time this evening. Such great information was shared. I know I learned a ton, and a huge shout out to everyone who attended and submitting such great questions. It was a wonderful discussion. We will be posting an event survey so you can let us know your thoughts. If you would like someone to contact you directly to schedule an appointment with a Jefferson Health provider, please go ahead and fill out the last question in the event survey. Be sure to also visit jeffersonhealth.org to make an appointment, stay up to date on upcoming events and webinars just like this one. A recording of this event will also be sent to you so you can rewatch at your convenience. If there's anything anyone here at Jefferson can do for you, please reach out to us. Thank you once again for joining, and please be sure to stay safe and healthy. Have a wonderful evening. Good night.